CCC for asking me to speak today. I'd like to just tell Dr. Chambers how inspired I was about her talk. I was in Toronto last night meeting with a bunch of IBD nurses, and we were talking about how to disseminate information, and quality information for patients on IBD, and we did go the whole, well, maybe we should talk about, Twitter and moving that way. So I was really excited to hear you talk. You've been very, yeah, you've been very successful, which is wonderful. So when I first started this 19 years ago, I got hired by Capital Health as the Nurse Practitioner in Inflammatory Bowel Disease. And I thought, okay, that's great. Well, somebody else has got to be doing this somewhere. So I'll just find out where the other ones are and I'll see what they're doing. And there were no other ones. There were very few nurses in IBD in the country at all. There were no nurse practitioners practicing in IBD. So we had to kind of develop it as we go, and we had to learn as we moved forward. And we had lots of growing pains and lots of changes, but it's been a wonderful experience and it's been a wonderful role. So I'm really excited about it, and I'm still excited about it 19 years later. The symptoms can have a profound effect on the patient's quality of life, and that's where we as nurses come in. Since it's often painful and socially undesirable. And if you want to find out how socially undesirable it is, sit with patients in clinic like I do every day. Dealing with frequent bowel movements and abdominal pain and bowel accidents and the embarrassment of it all is life-changing and life-altering. And I think that as healthcare workers, we don't really fully appreciate that, what exactly it means to patients and their lives and the way they move through life. So why do we need nurses in IBD? First of all, because it's lifelong. You need to develop that relationship with a set of nurses. You need to have that understanding. You're going to have this forever, and you need to be able to go somewhere and find help when you need it. And again, it significantly impacts the quality of life. And if I were to ask my physician colleagues what health was, traditionally, medicine has been, physicians and medicine has focused on the cure. So, but health is making the disease go away. Health is solving the problem, health is fixing it. Nurses think differently and we're educated differently. For us, health is improving quality of life. Health is the ability to function. Health is to be able to do what it is that you want to do. Right? So we have different approaches. Both approaches are extremely important, and I think only with the combination of those two approaches can patients really get quality care. So nursing is concerned with health, whereas medicine focuses on the cure. Medicine has changed a little bit, so it's moving more towards quality of life, but typically that's kind of the nursing perspective. So with this in mind, when I first started, and I couldn't find anybody who was doing this, I did find an article from a nurse in the UK, interestingly enough. Her name was Nightingale. And she had written an article on the development of an IBD nurse specialist role. And it became, for lack of a better term, it became my Bible. And I used the article a lot because she had done some of this. She had done things like developed a patient helpline. She had done things like tried to improve access, and she had done things like, focus on education and learning for patients. I contacted her, we emailed one another, we called one another, and she was, I've never met her, but she was my mentor. And over the course of the last, 19 years, there has been an evolution in the care of patients with IBD. And now, currently in the UK, there's a whole set of, they're called NECO guidelines, so Nursing European College Guidelines, on what nursing should look like in IBD. And that, it's wonderful. They have very strongly developed the nursing role, largely based on the work of Nightingale. In Canada, we're getting there. It's been a slower process. There aren't as many of us, and we're trying to increase the number of nurses in IBD, but it's a bit of a struggle. In 2014, Canadian Digestive Health came out with the best practice guidelines, and first of all, they recommended IBD be recognized as a chronic illness, which it's not in a lot of provinces. I don't think it's recognized anywhere, is it, Ian? And it's, when a disease or a condition is recognized as a chronic illness, funding follows. with the provinces, and physicians are, for example, given more time with patients who have chronic illnesses and are compensated properly for that. That's not the case in IBD yet. It hasn't been designated a chronic illness, so that's one of the things we have to do. They feel that there certainly needs to be more funding allocated for IBD, creation of IBD centers of excellence, and we're moving toward that in Halifax, and we're really working to meet the criteria for the development of such a center. And the adoption of a multidisciplinary care team. And this is key. I mean, there's all kinds of people who are going to be involved in the care of patients with inflammatory bowel disease. They all have their areas of expertise, and the best care will come when they all work together as part of a team. And, IBD nurse specialists are seen to be a key part to that team. And of course, data collection and measurements, looking at the outcomes of some of these roles. And this is not easy work, because when you have a team of 10 different people, how do you measure the outcome that one particular person or one particular role had on that team? It's difficult often to tease that stuff out. Oops, I went the wrong way. So in Halifax, we have gotten together a team. We have a clinical psychologist, 2 nurse practitioners, myself and my colleague Barbara Curry, nutritionists. That has been a bit of a problem, hard as it may seem, but getting a nutritionist for IBD has been proved difficult. We finally seem to have managed a half-time position. Gastroenterologists, we're very fortunate. I work with a large team of gastroenterologists. A new role that we've gotten in Halifax, and I'll talk about that later, is the role of the nurse navigator, researchers, and an IBDologist. We have 1 IBDologist in Halifax, and that's soon to change to 2 in the summer of this year. So talking a little bit about nurse practitioners, and that's my role. So we're all registered nurses with advanced education and expanded scope of practice. As nurse practitioners, we have the knowledge and the skill to diagnose and treat acute and chronic illnesses. We prescribe medications, we order investigations, and we consult to other specialties and receive consultations from others. Health promotion and illness prevention is a key part of what we do. Okay? In our practices in particular, with the declining number of family doctors, or the large number of patients who don't have family doctors, we find we're doing a lot of health promotion and illness prevention, and it's not always about the IBD. We're filling in the gaps from others. Nurse practitioners in Nova Scotia provide a broad range of services to clients in a variety of practice settings, such as community clinics, emergency rooms, collaborative emergency centers, hospitals, and long-term care facilities. So there are quite a few of us. There were 10 of us when I started. I think there's close to 180 or 190 nurse practitioners in Nova Scotia now. They are fully accountable for their care. So we are accountable for our own decisions, essentially, and including individuals, the care we provide to individuals, families, and communities. So to become an NP in Nova Scotia, you have to have a master's degree. And you have to have a master's degree as a nurse practitioner. You have to complete an improved education program, meet the entry-level NP competencies, pass the NP examination, and fulfill all the requirements of the College of Registered Nurses. NPs then establish a collaborative practice with a physician or a group of physicians. So what that means is you basically establish a partnership. In Nova Scotia, you can't be employed by that physician. So what's happened is I'm employed by Capital Health or Nova Scotia Health Authority in primary care. Very often in family doctor's offices, the NPs are employed by the province or the provincial health authority. So we can't be employed by the physician, but we have to work in collaboration with the physician. Okay. So in January 2002, I started this journey, and I developed a collaborative practice agreement with, at the time, 4 gastroenterologists at Capital Health. It was the first such collaborative practice in Canada. Nobody else was doing it. And the goal was to increase access to quality care. So what we knew at the time was that when patients could penetrate the system and get into the system, that they got pretty good quality of care. The problem was the walls to get into the system. So we wanted to improve access, improve patient knowledge of IBD, and encourage self-care It was amazing to me when I first started here, and I would say to patients, so where's your Crohn's? What part of your bowel is involved? And you'd get a blank look. We developed education programs. As part of it, we had a diagram with the gut, and we would say to the patients, take this back to your doctor, have them put X's where your disease is. It's important that you know the location of your disease, because depending upon the location of the disease, your symptoms may be different, or you may have different medications prescribed for you. And it took, it was shocking to me that people didn't know that, and now it's much more common for patients to be involved. Things like now they're getting CORI reports. They're getting, after you have an endoscopy, very often in many centers they'll get a report of the endoscopy in their hands with the pictures of their bowels, and this is the small bowel and this is where your disease is, and that makes all the difference in the world. Because you are going to go from care provider to care provider to care provider throughout your life, and the only person who's consistently going to know that history and what's been going on is you, and you have to own that. So key to development of this role was I had a lot of learning to do, and I had a lot of learning about IBD, so I had an extensive orientation. I had an NP mentor. She was an NP in hepatology, but she was an amazing NP, Jerry Hirsch, and she was absolutely fabulous when I started out. And we had really good administrative support. So these roles take time to develop, and they take, they take a lot of energy, but I think in the end, they make a big difference. So what does an NP, what should my NP look like? She should have extra, really good interpersonal skills. She should be a good communicator. She should be sensitive to her patient's needs. You need to know what it is the patient wants to accomplish. You need to say to the patient, what is your goal of therapy? What do you hope to do? What do you hope that we can help you with? What is limiting you that you would like to be different? We sometimes get so focused in what we think is best that we don't ask patients what is best for them. And as an example, I had a patient not that long ago who was flaring, and I was all gung-ho, let's avoid steroids, avoid steroids, avoid steroids. We're going to do this and do this and do this to try to avoid steroids. And she looked at me and she said, I've been on steroids 4 or 5 times in my life. And I said, yes. And she said, and I know I'm going to have to go on another treatment, but you're telling me it's not going to work for, 6 weeks or 8 weeks. And I said, yes. And she said, but my daughter's getting married in 2 weeks. So I want to really enjoy that wedding, and I want to really be able to help her with that wedding, and the way I am right now, I can't. So I don't mind if you put me on steroids. In fact, I want you to put me on steroids. And I thought, okay. But see, my goal was to prevent steroid use. Her goal was to help her daughter with her wedding. And we have to be able to really focus on the patient's goal to know where they are. And I mean, ideally, steroids are not, something we like to do, but you know what? That was a risk that she was willing to accept. She knew the side effects. She was willing to accept the risk, but she wanted to feel better for this important event in her life. So we have to consider the patient's goals and what they want to accomplish. And we very easily get focused on what we think is best, and it's not always what's best for them. We have to be flexible, you have to roll with it, you have to have cultural awareness, be part of a multidisciplinary team, and I'm very fortunate to be part of a really great multidisciplinary team where we communicate really well together, we work together, we help one another. Any one of the members of the team, I could say, could you help me with this? And they would. So I'm very fortunate that way. Provide holistic care and health promotion, and convey and promote positive attitudes regarding IBD. And that's important. I mean, patients come to me after a new diagnosis, and they've been sick now for 6 months. And they look at me and they say, is this it? Is this the way I'm going to be living forever? Is this what my life is going to look like? And they need to hear things like, okay, so the vast majority of my patients march in here a couple of times a year to have routine follow-up, and then they march out. Fine. Living normal lives, having families, having kids, and working. From time to time, they'll have a flare, they'll come in, we'll help them, we'll get through it, and then they'll go back. That's the majority. And we forget that as clinicians, that's the majority, okay? The minority are the patients who really struggle and who don't have long periods of remission, but those are the ones we see all the time. So we get skewed, right? So you have to remember that the vast majority of patients with this disease live normal lives. And our goal is to really help you to do that. And we have to present to you that that's possible and that that's what we want for you to have. And we have to do things like make connections with other people for you who are doing well. And CCC is an excellent way for people to make that connection. So the initial plan, I laugh when I read this slide, was for the NP to follow the stable patients with IBD. And that lasted about 6 months. And we realized very quickly that that's not where the need was. The need was in the high acuity patients who were really not well, who really weren't coping well, who really were not doing well on medications, who needed more help. So very quickly, we stopped, now I don't see anybody who's stable really, but very quickly we realized that what we needed to do was focus on the patients who had the greatest need. So, we changed the way we practice, and this is all about the evolution of this role and as it's happened over the last 15 years or so. By 2006, I was capped. I was by myself as an NP. At that time, around that time, we had a mass exodus of GIs from Halifax, and it was rough. So we applied for funding, and fortunately, we got a second NP. So Barbara Curry joined the practice, and again, there's an evolution, and you change things up. But there has been times when we've had to say, hold it. We can't do anymore, we can't see anymore, and we've closed our practice, but then we readjust and maybe, send some patients back to their family doctor or send some patients back to their GI, and then we start again. So what have we been up to? So currently, we follow a large IBD patient population, most of whom are on biologic or whom have additional needs. So high psychosocial needs are, young people. We follow all the transition patients. We really don't want to, the risk with patients as they go from pediatric to adult care is they get what we call loss to follow-up. So they don't show up for their appointments in the adult world, they get off their medications, they get sick, they get hospitalized, and we want to break that cycle. So we follow all the transition patients. We do go to their last pediatric visit at the IWK, we call it transition clinic, and then we book their first visit with us in adult care. Patients who have high psychosocial needs, we tend to follow. Patients who have a lot of educational needs, we tend to follow. And patients who have the sickest IBD, we tend to follow. We do approximately 1,400 patient visits per year, and we have a telephone helpline for patients that takes in about 1,200 phone calls a year. We have an ongoing transition clinic with the IWK. We provide education nights, things like this, and an education program that we've developed about 3 to 4 times a year. And we participate in research both as PIs and as sub-investigators. So fortunately for us, in 2016, there was another nurse hired into our program, and it's the role of the nurse navigator. So this role traditionally came from, if you look at it, it was first used in the cancer care model. So because when a patient is diagnosed with cancer, there's so many different specialties that she may have to see or he may have to see during that diagnosis, that they developed the role of this nurse navigator to help the patients move and work through that diagnosis. We use our nurse navigator much the same way. We use her as a quarterback to help the patients in and out of the system and to access the care that we need. So, she helps us with managing the patient helpline, and she's really, for the most part, taken over a lot of that role. And we have some data to show that since we've, developed this role and we have this role, our visits have gone up our new visits have gone up about 25%. Our return visits have gone up about 30%. That's the 2 NPs, and that's because she's been managing the telephone helpline. Interestingly enough, our urgent access visits have gone down by 20%. So what we think that means is she's managing a lot of that urgent care on the telephone. So it really has been a very valuable role for us. She's also doing vaccination clinics, pre-biologic for patients, and she with us has developed what we call a biologic care pathway. So when patients get diagnosed with IBD and they're going to be started on a biologic, there's a whole bunch of work that has to be done pre-biologic. She helps us to get all that done. She knows where to reach out to get some of that done. And then once the patient has been on a biologic for a certain amount of time, they get assessed with blood work and stool samples, and then they get a call from her to see how she's doing. So basically, we're trying to standardize the care that patients receive when they start a biologic and make sure everybody gets the follow-up that they need. We haven't rolled this across the division. We're just using it right now kind of as a pilot with a few practitioners, and it seems to be working, although I think it's a little bit of a labor-intensive endeavor. So this is a model of our patient flow through our practice, and you can see the nurse navigator is right in the center. She's that little gray circle. Patients flow in through her. They are able to access care through her, and we're hoping, we're trying to make it as streamlined and as easy as possible. There have been challenges along the way. Having the right people in the right teams and resources has been difficult. We struggled for a very long time to get access to a nutritionist. And when we first did get access, it was a 0.2 position, and we had 3 different people in the job in 18 months because nobody's going to stay in a 0.2 position. So now we've got 0.5 funding, so we're hoping that's going to make a difference. These gastroenterologists retire, and that's proved to be a bit of a problem because people have left. And when you are a gastroenterologist and you have a large IBD patient population and you retire and there's nobody else to take those patients on, that's a bit of a problem. And right now, Barb and I, the other MP, are kind of holding a couple of hundred IBD patients, just floating until we have a new GI come to our practice in the summer. So it's been difficult. Space, believe it or not, is at a premium. Office space, clinic space. We've kind of captured a bunch of space out of the Cobequid, and we do clinics there. I go there Mondays and Wednesdays. We do a big collaborative practice, multidisciplinary clinic there on Wednesdays. But it took us a while to find physical space to see patients as the program grew. And measuring outcomes, we're very fortunate in that the head of the program is Dr. Jennifer Jones, and she's very keen on research and outcome measurements, and especially around quality of life and the development of different practice models. So we're very fortunate about that, and we have been working on managing outcomes. But before Dr. Jones, it was very difficult. I'm not a basic science researcher. Barb's not a basic science researcher. We knew we were making a difference, but having access to the ability to demonstrate that wasn't always easy. So that's the long and the short of it. That's what we do. Thank you so much for having me to speak. Are there any questions? Maybe, yes?
This hotline, is that just through the IWK, or is it for all patients?
So it's not the IWK, it's Capital Health, and it's called the IBD Patient Helpline. Anybody that we see, we give access to it. Some GIs do as well if they're concerned about you. There's a registered nurse, our nurse navigator, or Barb or myself are taking those phone calls, and we're trying to manage some of it. Our goal is to keep people out of the emergency room, try to see them quickly in clinic if we feel that we have to. Our nurse navigator will try to get investigations started, so if she talks to you and she thinks that things may be flaring, or she knows what we're going to do. We're going to check your stools for C. diff, we're going to do fecal calprotectin, we're going to do blood work, so she initiates all that. So maybe by the time I see you 2 days later, half that's done, and I have the reports back. So that's the way we're trying to manage things.
So my son is newly diagnosed and with a gastroenterologist. So if he did have a flare-up, we just call 311 for information?
Yes,
Where
or
do we get that number for the
so
hospital?
is he a patient at Capital Health?
Yes.
Well, he should be able to ask for that number.
Oh, okay.
And I'll talk to you and give you
Okay,
that number.
thank you.
Any other questions? Thank you very much.